Welcome to Endodocs. Here we break down the world of endodontics and dentistry in simple, easy to understand ways. Whether you are a student, a professional, or just curious, we will try to guide you through key concepts, innovations, and practical tips. Stay tuned for bite sized lessons that make complex dental topics a breeze.
Hi everyone. So today we'll try to learn the basic concepts of smear layer. Why is it so important in restorative dentistry or adhesive dentistry, and why there is still a controversy about it. So the smear layer is a thin film of debris that forms on the tooth surface during preparation. It spreads across the area and can block the openings of the dentinal tubules like this, creating what we call as the smear plugs. So this is the smear plug, and these are the smear layer that are present over the surface of the dentine. Now this smear plug, this is able to reduce the permeability of the dentine by about 86%. According to Studivant's operative dentistry textbook, the smear layer is mostly made up of hydroxyapatite and altered collagen. The friction and heat from the preparation process causes the collagen to change, becoming more gel-like or gelatin-like. This extra fluid on the surface can make it difficult for the adhesives like resin to bond with, since these materials need a different kind of surface. So the fluid from the dentinal tubules is making difficult for the resin to bind with the surface beneath it. Even if resin tags form inside the dentinal tubules, the presence of fluid and the smear layer can still compromise the final bond. Now, the reason the smear layer is so important is because one of the key principles of adhesive dentistry generally relies on either modifying it or removing this layer. Either we have to remove the smear layer or we have to modify the smear layer. So, in past, what we used is that we used a three-step total etch technique where we applied an acid, that is 37% phosphoric acid, that would remove the smear layer, exposing the collagen in the dentine and opening the tubules like in this diagram. These are the dentinal tubules, which can be seen as post treatment of the etching phase, and the openings are generally in funnel shape and allow the resin to bond by forming tag like structures. However, the problem with this method was that removing the smear layer increased the fluid flow onto the exposed dentin, which could disrupt the bonding since hydrophobic resins didn't stick well to the hydrophilic dentine surface. And also, if there is a fluid flow outwards, there is a chance of hypersensitivity or dentinal hypersensitivity. Even if resin tags formed, the fluid still got in the way, and later this approach was replaced by a simpler one bottle total etch system, which also exposed the collagen, opened the tubules, and helped bonding, but still had its own challenges with fluid and adhesion. Now we know the smear layer can be removed by using phosphoric acid, but it's really important to choose the right strength of the acid. Okay. So generally we use S3PO4 37%. But what happens if we use it in a lower concentration, say about 0.13% or till 20%? That is from 0.13% to 20%. Why specifically 37% is only used? So if we use a lower concentration, then there is a very gentler etching and the smear layer isn't fully removed. And earlier we used a three-step system, so the primer would not be able to properly condition the dentinal structure, microstructure, or the dentinal tubules in particular. Also, if we use a very higher concentration, such as suppose 65% or near about double the concentration of 37%, then there are weaker result and lower bond strength in practice. So the best acid considered is in concentration usually around 30 to 40%. With this method, the smear layer is completely removed, so it doesn't get in the way of bonding, and since everything is fully cleaned off, we are able to get a stable uh, resin tag like structures. However, over time, studies have shown that the collagen in the dentine breaks down faster with this etch and rinse systems compared to the self etch systems. And this might be probably because of the strong acid that removes more of the dentine's structure, exposing the extra collagen fibers. And as a result, natural enzymes in the tooth, that are the matrix metalloproteinases or the MMPs in particular, they get activated and they slowly break down the exposed collagen over the time, and the resin dentin bond gets weaker. So another way to deal with this problem is to adjust the smear layer by using a self etch method. So in this method, we are not removing the smear layer. So removing is not done in this case, we are rather modifying the smear layer. So what this means is we are using mild etch self etch adhesives that gently soften the surface of the dentine, and even after this some hydroxyapatite still stays behind, like in this diagram. What earlier was used was the complete removal of the smear layer, and only then the resin dentin matrix bond was formed. But in case of self etching approach, there was a modified smear layer, as we can see here in the diagram. So the since we gently soften the surface of the dentine, and even after this some hydroxyapatite still stays behind, so hydroxyapatite is still remaining behind, and this lets us form the chemical bond with the 10 mdp monomer, okay, which creates a stable calcium salt. Now this bond is what keeps the connection between the resin and dentine strong for a very long time. That's why the mild self etch adhesives are often better. Still, many universal adhesives also use the same 10 mdp monomer, and this monomer is a bit more hydrophobic than other types. In general, the pH of these universal adhesive ranges from about 1.5 to, in general, 3.2, which means most of them are considered either mild or ultra mild self edge. And because of this, we need to pay a very close attention to how the smear layer behaves when we apply these adhesives in a self etch way, making sure we get a good and reliable bond.
If you liked the video, please don't forget to like, share and subscribe to Endodocs.